Hi everyone, Dr. Obeng-Frimpong here again, and welcome to the TutorMed channel where everything medicine is simplified. In today's video, we will continue our discussion on the evaluation and management of chest pain in the adult patient. Remember, we've dealt with common cardiac causes of chest pain in our previous videos where we spoke about stable angina, acute coronary syndrome, etc. In this video, we will discuss the pericardial causes of chest pain. The playlist containing the cardiac causes of chest pain is in the video description below, and so kindly have a look at it if you have not seen those videos yet. Alright friends, let's begin the discussion. And so, as usual, let us begin the discussion with how we as clinicians should visualize our patient's chest whenever they come complaining of chest pain. And so from the back, we have the thoracic spine, 12 in number. Then in front of the spine is the esophagus, which is part of the gastrointestinal system. In front of the esophagus is the trachea and the two bronchi. Then we have the heart and its covering called the pericardium. And we are going to look at the common conditions which affect the pericardium, like we have mentioned. Again, still on the heart, we know that the great vessels, which are the superior and inferior vena cava, and then the aorta, should also be visualized at this point. Then we have the right lung and the left lung. From there, we have the rib cage, the sternum, and then the other chest muscles like the pectoralis major, which are not shown here. And then finally, we have the skin of the anterior chest. And so this is a mental picture of our patient's chest, and I hope that this created a fair picture in our heads, right? Very good. Now let's take a brief look at what the pericardium is, the covering of the heart. To understand this, let's look at the layers of the heart. The innermost layer of the heart is called the endocardium. The middle layer, the myocardium. And the outermost layer is known as the epicardium. Now, the epicardium is also called the visceral pericardium. Then we have the parietal pericardium, which is more pain sensitive than the visceral pericardium because it is innervated by somatic nerves. External to the parietal pericardium, is the fibrous pericardium. Now, in between the visceral and the parietal pericardium is the pericardial space, which is lined by a thin film of serous fluid. And so the pericardium has three layers. Working from the outside to the inside, we have the fibrous pericardium, the parietal pericardium, and the visceral pericardium, which in itself is the epicardium. And so, considering the conditions we will be discussing, the pericardium can be inflamed and cause a condition called pericarditis. And the pericardial space may contain an excessive amount of fluid which is able to impair cardiac activity, and that condition is called cardiac tamponade. And so we are going to focus on pericarditis and cardiac tamponade. And so let's begin with pericarditis, the inflammation of the pericardium. Clinically, pericarditis can be classified as 1. Acute pericarditis, subacute pericarditis, and then chronic pericarditis. Pericarditis lasting less than 6 weeks is known as the acute pericarditis. And then subacute pericarditis lasts from 6 weeks to 6 months. And then pericarditis lasting more than 6 months is a chronic pericarditis. And so, as usual, like I've always been saying, anytime you have 3 categories, take note of the middle one and you will be able to tell what the extremes are. However, I should quickly point out that the Ghana Standard Treatment Guidelines rather define chronic pericarditis as lasting more than 3 months instead of the 6 months documented in Harrison's Principles of Internal Medicine. But I would like to stick to the classification outlined or illustrated in Harrison's Principles of Internal Medicine. And so among the 3 classifications, we'll focus more on acute pericarditis, the form of pericarditis lasting less than 6 weeks. Now, we need to know the causes of pericarditis because remember that as clinicians, one of our principal mandates is to establish the cause of our patient's problem. And so for the causes, we can use the mnemonic VINDICATE. V stands for vascular, and so vascular causes of pericarditis, you can have post-myocardial infarction, and so pericarditis may follow myocardial infarction. And then I in the VINDICATE mnemonic stands for infection, and so the infections could be viral, so viral causes like Coxsackie A and B virus, adenovirus, HIV, etc. Then we can have bacterial causes, and we can have mycobacterial causes, so TB pericarditis, and then fungal causes. Then N stands for neoplastic, and so we are talking about the cancers. So we have primary tumors of the pericardium or metastasis to the pericardium, so metastatic pericardial tumors. Then D in the mnemonic stands for drugs, and so drugs like hydralazine, which is an antihypertensive, isoniazid, which is an antituberculous drug, phenytoin, which is an anticonvulsant, and some anticoagulants can also cause drug-induced pericarditis. And so we have done V, I, N, and then D. And so the next I is idiopathic. So idiopathic pericarditis. Then C stands for congenital, but I want to put familial pericarditis there. It runs in the family, right? Then A stands for autoimmune. And so autoimmune conditions like rheumatic fever, connective tissue disease like SLE, the full meaning is systemic lupus erythematosus. Then we have rheumatoid arthritis, and then Dressler syndrome, recurrent pericarditis that can complicate myocardial infarction, and it's an autoimmune process. Then T stands for trauma, and so traumatic causes including post-pericardiotomy, that is post-surgery, and then post-irradiation. Maybe the patient has a mediastinal tumor which needs chemoradiation, and then we damage the pericardium during the irradiation procedure, so post-irradiation. Then RTA, road traffic accident, can also cause traumatic injury to the pericardium, leading to pericarditis. Then E stands for endocrine, but this can also mean metabolic. Okay, so we want to use the metabolic there. So metabolic causes like uremic pericarditis. Uremic pericarditis is a complication of chronic or end-stage renal disease. So someone with chronic kidney disease can have pericarditis, and that will be because of uremic toxicity. And so these are the few causes of pericarditis we should take note of. Vindicate. All right. Very good. And so please do not forget to like and share this video and subscribe to our channel if you have not done that yet. Now, how do we make a diagnosis of acute pericarditis? As usual, we always begin with a clinical history. And so we establish the relevant demography, the patient's name, age, sex. Then we come to the presenting complaint. In most cases, the presenting complaint will be chest pain of a short duration, because we are talking about acute pericarditis. Then we come to the HPC, the history of the presenting complaint. And if you have watched a lecture on history taking, you'd realize that for the history of presenting complaints, we need to establish the characteristics of the presenting complaint. And so the presenting complaint here is chest pain. So the characteristics, we establish it using Socrates. Okay, so the site of the pain is usually retrosternal, or sometimes it can be located in the left side of the chest. That's the left precordial region. Then the onset may be sudden or gradual. Then what are the characteristics, or the character? What is the character of the chest pain? It is pleuritic. Remember, pleuritic chest pain is chest pain which is worsened by coughing or by deep inspiration. Then R for radiating sites. So pain of pericarditis usually does not radiate. Then remember that R can also mean relieving factors. And so the pain of pericarditis is relieved by leaning forward. And when we progress, you would know what worsens it. But I'm saying that the patient feels relieved when he or she leans forward. Yes. And so we have A, associated symptoms. So it may be associated with difficulty breathing or dyspnea. Then T for triggering factors. Usually there are no triggers. Then E for exacerbating factors or worsening factors. And so the pain is worsened by lying recumbent, or by the patient lying on his or her back. And so pain of pericarditis is sometimes described as positional. It is worsened by lying flat, and then it improves when the patient leans forward, like we established earlier. And then S for severity. The pain of pericarditis is usually severe. Now, although the most common presenting complaint is chest pain, there are some causes of pericarditis which are painless. So I have chosen to describe them as painless pericarditis. And then the mnemonic I use for them is TUMP. TUNP. So T for tuberculous. Tuberculous pericarditis is usually painless. So is uremic pericarditis. Then pericarditis of neoplastic origin. And then post-irradiation, TUMP. And so you know that from your history of presenting complaints, you come to your on-direct questioning. And remember that on direct questioning, one of the aims there is to establish the cause of the patient's problem. Now, maybe the history of presenting complaint has given you a clue that this pain is most likely from pericarditis. So on direct questioning, we need to establish the cause of the pericarditis. And so you ask questions going through the vindicate. If you want to know whether it is from a post-myocardial infarction, you may need to ask for any past history of myocardial infarction recently. If you think it's from infections, you need to ask questions like fever. If you think that it is from a neoplastic cause, you need to ask about any symptoms of cancer. Drugs, you need to find out the patient's drug history, whether he is on any of the medications we listed that they could cause pericarditis. And then I for idiopathic, we don't know. So after you have asked questions to rule all these, then you can dwell on idiopathic pericarditis. Then another thing you have to do in this aspect of the history taking is to exclude other differentials of chest pain, because although the history of presenting complaints may point out that this chest pain is of pericardial origin, you need to prove beyond doubt that you've ruled out other differential diagnoses. And so you need to ask questioning If it could be acute coronary syndrome, myocardial infarction or unstable angina, you need to ask questions to rule out pulmonary embolism. You need to ask questions to rule out pneumonia, aortic dissection, and other common causes of chest pain, so that in the history presentation, if you are asked about your diagnosis and then you say it's pericarditis, you can get grounds to defend your diagnosis because you actually asked questions to establish the cause of the pericarditis, and you asked questions to exclude other common differentials of chest pain. And so on examination, the patient may be seen in pain and may be in respiratory distress. Then on auscultation of the chest, there will be a pericardial friction rub heard. So it is heard at some point in the illness in about 80% of patients. So you may not always hear the pericardial rub. And it is heard frequently at the end of expiration when the patient is upright and leans forward. And so you ask the patient to sit up and lean forward and then exhale to the maximum. And if it is there, you can hear the pericardial friction rub. And it is usually heard in the bare area or on the bare area of the heart, the part of the heart which is not covered by the lungs. So maybe in the tricuspid area of the precordium. Then apart from the pericardial friction rub, you may find features of the underlying secondary cause. And so if it is TB pericarditis, you may find stigmata of TB. Maybe the patient is cachectic, the patient has lymphadenopathy, and the patient has chest signs of consolidation. If it is chronic kidney disease, you may find that the patient is edematous, maybe pedal edema, facial puffiness, the patient is pale, etc. Then apart from that, you may find features of cardiac tamponade or tamponade, I wanted to say, as a complication. Acute pericarditis or pericarditis may cause pericardial effusion, which is severe enough to impair cardiac activity, and that is cardiac tamponade. And so you may find that maybe the patient has muffled heart sounds, the patient has a raised JVP, and the patient has hypotension. And so all these are features that can be found on examination, which we should look out for. And so let us move to the investigations we can do for a patient with pericarditis or acute pericarditis. So we can do a 12-lead electrocardiogram, a 12-lead ECG. So this is an ECG showing a patient with pericarditis. I'm going to illustrate some things on the various leads. So look at lead 1. You can see this saddle-shaped ST elevation. You can see the same in lead 2. Lead 3, it appears inverted. And look at AVL, that's saddle-shaped ST elevation. Look at lead V3, the same for V4. Look at lead V5, and look at lead V6. And so one of the ECG changes is that you have a diffuse or a widespread saddle-shaped ST elevation. It suggests acute pericarditis. And also, you may have some depressed PR segments in most leads. And so a diffuse saddle-shaped ST elevation and then depressed PR segments in most leads for the 12-lead ECG. And so other investigations that can also be done include a plain chest radiograph. And so the chest X-ray can show an enlarged cardiac shadow. So you have a pericardial effusion from the pericarditis, especially if the effusion is more than 300 mils, but this may not cause cardiac tamponade. This is just pericardial effusion from the acute pericarditis. Or the chest x-ray may also rule out any other differential diagnosis like pneumonia. Then you can also do an echocardiogram to localize and quantify the fluid. You can also do a CT scan or MRI to confirm the pericardial thickening. Then full blood count, ESR, cardiac enzymes, BU creatinine can be done. Full blood count may show elevated white blood cells. ESR may be elevated because there is an inflammation, and we need to do cardiac enzymes because we need to rule out myocardial infarction. Sometimes there is a condition called myopericarditis, and so there is myocardial infarction which has spread to the pericardium. Okay, or there is myocarditis, which has also the inflammation has spread into the pericardium, and so you can have cardiac enzymes elevated in acute pericarditis. Then BUE creatinine to evaluate the renal function if you are thinking that it will be from a uremic pericarditis, and so on. And so let's talk about the management of acute pericarditis. I should mention that there is no specific therapy at the moment. We encourage the patient to rest, and so bed rest. And then we give NSAIDs like aspirin or indomethacin for the pain. And because he's going to be on it for some considerably long time, we have to give gastroprotection, protect the gastric mucosa with omeprazole, because NSAIDs can cause gastritis. And then for those who respond to the NSAIDs, we have to continue it for 1 to 2 weeks and taper it down over several weeks. Then in addition to the NSAIDs, we need to give colchicine for 3 months. The added colchicine enhances response to NSAIDs and reduces the recurrence rate of acute pericarditis. But colchicine is contraindicated in patients with renal or hepatic dysfunction, and so renal or liver impairment patients shouldn't be given colchicine. Glucocorticoids like prednisolone may be tried in those who have failed NSAID therapy or those with uremic or collagen vascular diseases like SLE and rheumatoid arthritis. Those who cannot be on the colchicine or on the NSAID, we can try methylprednisolone, and it usually suppresses the clinical manifestations, but there is a high risk of recurrence, and so full dose steroids should be given only for 2 to 4 days and then tapered down. And so this is the end of the discussion on acute pericarditis. We will discuss in our next video cardiac tamponade, which is the last condition we want to discuss in this module, the patient with pain of pericardial origin. And so thank you for watching this video. Kindly support us by liking and sharing this video, and subscribe to our channel if you have not done that yet. So see you in our next video, and until then, have a good day.